Hello, my name is Dr. Leroy Jones. I'm currently in private practice with Urology San Antonio, and we're going to talk about male incontinence. So urinary incontinence can be a very debilitating problem, and this slide just depicts a friend of mine, probably exaggerating things, but you become very dependent on diapers, and it's a very difficult thing and severely affects quality of life. So what can we do? When we look at male incontinence, the main reason that we see patients for urinary incontinence is that they've had some type of radical pelvic surgery or some type of pelvic trauma. Certainly birth defects may contribute to it, but primarily radical pelvic surgery, so maybe a procedure for prostate cancer or an enlarged prostate, and that can affect the urinary control mechanism. So what do you do for patients? Well, we evaluate them very thoroughly. We look inside with little telescopes. We also will do tests on the bladder, seeing how the bladder functions. Once we kind of get past that point, these are some of the treatment options that patients will experience. Pads, catheters, and clamps. I mean, obviously this is not a long-term solution, more of a temporizing solution until they ultimately get definitive treatment. Kegel exercises, and that's basically where the patient will contract and then relax the perineal muscles, and that's the muscles important for control of the urinary sphincter. And so many patients start the exercises with after prostate cancer surgery to hopefully regain continence. Medication. Medications are primarily for overactive bladders, and when you look at reasons for leakage in males, they can have an overactive bladder, urge incontinence, and that's a sensation where they feel they need to get to the bathroom and it's so overwhelming it starts to get out before they get to the bathroom. Or there's stress incontinence. The stress incontinence is when the individual, they may lift something heavy, cough, sneeze, or laugh, and then that causes leakage. So the medicines are primarily for an overactive bladder. It's not going to do much if the patient has stress incontinence, but again, through history taking, we can try and discern what the issue is. Next is injectable bulking agents. Now these we used a fair amount many years ago, probably 20 plus years ago, and there was great interest in them. But a lot of that interest has gone away, and primarily because it's not a long-lasting type of a treatment that's more temporizing. And so we've really moved on to more definitive treatment. So the definitive treatment that's out there are the male sling and then the artificial urinary sphincter. We first of all try to characterize or break down the severity of the incontinence that the patient may suffer with. So mild, moderate, and severe. 1 to 2 pads a day is probably considered more mild. 3 to 5 is moderate, and then 5+ pads more severe. And that will help us determine what type of treatment options we'll recommend to the patient. We also will sometimes use pad weight tests where we actually weigh the pad because some patients may change the pads more often really before they're damp, and other patients may leave one pad on and it gets quite heavy. And so, but all of this can generally be determined during the history taking of the patient. The artificial urinary sphincter is something that's been around for over 40 years and really is a gold standard on for the treatment of incontinence, primarily for post-prostatectomy incontinence. And again, these are the patients who have moderate to severe incontinence. It's all placed through 2 small or 1 small incision. These procedures are outpatient procedures that take approximately 30-40 minutes to do. When you query patients about satisfaction and would they do it again, in excess of 90%, and you can kind of get an idea of what's going on here. So this is the pump that's in the scrotum. This is the cuff that goes around the urethra, and then this is a little reservoir. So the reservoir provides positive pressure, and the pressure is to the cuff of the urethra. Because the patient's own urinary sphincter is not working, you need to have something squeezing on the urethra to prevent leakage, and so that's where this comes into play. And when the patient wants to urinate, they squeeze this button, the cuff relaxes, fluid goes back into the reservoir, patient is able to void, and then it auto-fills on its own. And this is just a slide that basically dictates that, and so you can kind of see when the patient wants to go, They squeeze a little button, fluid leaves the cuff, it goes back to the reservoir. The patient is able to void without any problems. And then once they're done voiding, the fluid then returns from the reservoir back to the cuff, and it squeezes on the urethra, and then the bladder can fill again. And so again, this is a very amazing device that's been around for over 40 years that really returns quality of life to patients in a great fashion. It's totally concealed, very easy to operate. Lots of studies have been around, very durable, will last for many, many years, 10 plus years, and does affect the quality of life. And really, when you ask patients about the artificial urinary sphincter, most of them regret waiting. They feel that they probably should have had this done sooner because there was some hope that the incontinence was going to return. Typically, after a patient has had prostate cancer surgery, I mean, and situations vary, but generally you'll wait a year. But really, if it hasn't returned by a year, it's likely not going to return. The male sling is something that's been out now for several years, about 7 years. It's a newer technique, and it's a version of an operation that's been available for women. Urology San Antonio, where I practice, was initially one of 8 sites when the device was introduced a number of years ago. And again, this is for patients with mild incontinence, and the results have been very nice. The best way to think about what the sling does is think of it like a hammock. It provides some support to the urethra, and that actually allows the sphincter muscle to function much more efficient. And as a result, this will really greatly improve incontinence. It's a single incision. It's a 30-minute outpatient operation again, and it starts working immediately, although the patient, we don't want them too active after they've had this done to allow the device to heal in place. But this is perfect for the patient with mild incontinence, maybe 1 to 2 pads a day, or there are certain weight limits on how much they leak, and then this way they don't have to manipulate a button in the scrotum. And so the results have been very good.